Thank the organizer for the opportunity to present this work remotely. My name is Rafael Sebastian, and I'm going to present the work Personalization of Ventricular Cardiac Conduction System Models to Reproduce Patient Electrocardiograms, which is a collaboration between University of Valencia and the Institut Bordeaux Athletics. As you know, cardiac function is controlled by the cardiac activation sequence, which in turn is controlled also by the activation of the fast conduction system of the heart, and as a result produces a typical activation sequence that you can see there summarized in 4 different steps and gives rise as a result to the QRS complex here. We are going to try to see a methodology to generate this patient-specific QRS data. The information about the activation sequence of the heart has been mapped for years. In the early 70s, there is the seminal work of Darwer in circulation that showed using different needles, up to 870 needles all over the myocardium, how was the activation of the heart in a human heart. Other works, like the one of Meyerburg, also mapped the activation of the Purkinje system together with the activation of some sections of the ventricles. However, this was done ex vivo. If we want to build a patient-specific model, we can use other techniques. One of the most common or famous one is ECGI, which is electrocardiographic imaging, which is based on the estimation of the activation sequence or the potentials or electrograms at the epicardium, and in some cases also in the endocardium, from a large number of electrodes, up to 250 electrodes at torso level. However, it has the problem that it requires specific technicians to place the electrodes, to perform the estimation, and you need a reconstruction of the torso beforehand, and that makes it difficult to be used routinely in the clinic. Some other techniques that have been presented recently only require the 12-lead ECG. In some of them, a reconstruction of the full myocardium is required to estimate inversely the location of the early activated sites of the ventricle, and in some recent works also using forward simulation in a loop. They were able to simulate and compare the results of the simulations with real ECG up to they find a match between the simulated and real ECG, and like that they obtain the activation all over the ventricle, as you can see in the picture. However, these models do not take into account the cardiac conduction system. In this figure that you have here, we have the activation sequence observing a 12-lead ECG using 3 different techniques: a patient-specific model, which is depicted in black, Darwer activation sequence, and a generic Purkinje system developed by Fractals compared with the clinical data. And as you can see, only the one that was estimated or only the one that has a personalized Purkinje system can reproduce the morphology and the polarity of the 12-lead ECG, while the others has shown less correlation and accuracy. So now I'm going to show you how we obtain this patient-specific Purkinje system to obtain this match between clinical and simulated data. The algorithm is divided in 5 steps that we are going to revisit now, from the electroanatomical map to the biophysical simulation. So the first step is to obtain electroanatomical maps of different patients. We have 26 electroanatomical maps that belong to 13 patients, 13 for the right ventricle, 13 for the left ventricle. Because the data is very noisy, the data that comes from the electroanatomical maps, and there are large gradients in the data which are not physiological, we decided to do a re-annotation with a custom code, a tailor-made code. And you see there in the center of the figure the difference between the electroanatomical map and the one after we re-annotate it, which is much smoother and probably more accurate than the other one. With this data, we estimated the location of the Purkinje myocardial junctions, or the early activated sites on the endocardium. So the red crosses represent data that has been acquired. Then with this data that has been acquired, you perform a backward iconal problem in order to find the locations at the tissue which can be the sources of activation for all of them, for all these acquired points. So when at least 3 points point out to the same location and the same time, we define an early activated site there. We do this for all the points that have been acquired. Some of them do not actually point to any real PMJ, but some others group together in clusters pointing to the same source. So we keep these sources of information as the Purkinje myocardial junctions. After that, what we do is we take all these Purkinje myocardial junctions. In the figure, you can see them as these color spheres, and we try to estimate a compatible structure. So first, we place the first branch, which goes from the atrioventricular node to the apex. Then we try to connect to this initial structure the different Purkinje myocardial junction given a conduction velocity in the Purkinje system. We do it iteratively, so we connect them in order to match exactly the time where they have to activate until no more points can be connected. So we do this iteratively, increasing the allowed error. So at first we only let points connect with 1 millisecond error, and then every time we increase when we cannot connect more points, we increase in 1 millisecond up to 5 millisecond maximum to connect all the points. As a result, we have a Purkinje tree. Now we are going to see how this algorithm works, first with synthetic data. So we have these 5 different models. We estimate the location. We compare because these are synthetic, we know where are the location of the real Purkinje system and the ones that were estimated, that here are depicted with red spheres and blue squares, and then we measure the error or the distance between them. And the distance was pretty short, between 1 and 3 millimeters in the worst cases, depending on how much error we included in the samples. Then we did the same with the times. So here we have models with 0 error, 0.5 millisecond error, and 2.5 millisecond error in average. That we incorporated to the data to make it more difficult for the algorithm, and these are the results that we obtained. Also, here you have the original data and the estimated one with different errors incorporated in the data. And as you can see, the more error makes it more difficult to reconstruct, but they were pretty low. We did the same for the real cases. This is the particular case of patient 12 with his Purkinje system structure and the location of the PMJs. And here you have the simulated epicardial and endocardial maps and the real ones obtained from the electroanatomical map. And you can see just visually that they resemble pretty much one to the other. Quantitatively, we did the same for all the cases, and here you can see the time errors between the real electroanatomical map and the estimated one, which were for these cases in the order of 4 to 7 millisecond errors. In that particular cases, which basically are the best ones, we observed that many of the samples acquired pointed to early activated sites. This is the percentage of activated sites that has some related samples acquired in the electroanatomical map. When this number is very low, means that many nodes from the electroanatomical map don't point to any early activated site, and therefore the error is very, very big. In these models, in average, we obtain optimal conduction velocity for the Purkinje system of 1.95 meters per second, which is in the physiological range, and 6.8 millisecond error in average for all the points. Here you have visually, in this projected 2D plots, the activation sequence in the original cases and estimated only with early activated sites and also including the structure. And you can see also that the patterns resemble pretty well the original ones. When we simulated with these activations the ECG, the match was very good, and then the Pearson correlation for all of them was pretty high, in the order of 0.75 up to 0.98, with some exceptional cases that were not correlating well, but the morphology and the polarity was always good, not always the amplitude. So, in conclusion of this work, We have developed a methodology to estimate the minimal Purkinje myocardial junction and Purkinje structure, including also the conduction velocity in tissue in the Purkinje. And we think that this is important because in some cases we are going to use this computational model to simulate arrhythmias that can be triggered by the Purkinje system or even sustained. So the structure is important. The conduction velocity estimated in the Purkinje was 1.95, which is in the order of the works that are presented in the literature that you have summarized here with different conduction velocities obtained. The average error when we compared the electroanatomical maps and the data was for the early activated sizes 6.10 milliseconds. When we included the structure 6.8, which is in the range of other works presented in the literature that also estimate the Purkinje system, and the correlations obtained between simulated and real ECG were very high, as we've seen in the previous slide. So thank you, and if anyone has any doubt, I will be delighted to answer it.